2 will be on the ECMO stuff in the back of the room because we are starting to do more transfers between here and Barnes. They probably aren't going to go to MOBAP, but they could go to MOBAP depending on bed availability. And then hour 3 is on ventricular assist device, or VADs, not just LVADs. There are some RVADs and BiVADs out there. It's going to be put on by the children's folks because they have more staff available to come up here for the 3 training sessions. But essentially, they're just smaller versions of the adult. So you can even say that kids are just small adults. See how they react. And yeah, that'll be it. That'll be the 3 lecture topics this month. So getting started. Why do we vent or put people on ventilators? How do we do it? What is lung protective ventilation? Some generic knob and buttonology, and then finally some case stuff. And then we'll get some hands-on. We'll bring everyone up and let them play with the lung simulator and see how the ventilator reacts and whatnot. So reasons for ventilation, it's similar to reasons for needing any kind of plastic in the throat or trachea. It's loss of airway protection, failure to oxygenate, failure to ventilate, which are two separate entities. And then finally, expected clinical course. So if you get 90% body surface area, 3rd-degree burns, you're going to be in a world of hurt and need to be on a ventilator so they can treat your pain and treat some other things. So you may have no involvement of your airway, be oxygenating and ventilating just fine, but they know it's going to be that you're going to need to be basically in a coma for a while so they can do a bunch of things to you. And you guys may need to put people on ventilators. We haven't yet gotten enough of these out to the 911 trucks to where you guys have them available for like the supervisor to show up. But the hope is that in the future, with funding, that you can then convert a post-cardiac arrest patient or a head injury patient or someone who needs very meticulous mechanical ventilation as opposed to the lowest trained person squeezing the BVM. You will be able to remove the human factors out of it and start them on a mechanical ventilatory support. So when you hear in the hospital like, oh, these are the vent settings, you're going to hear some things like control and assist and supported or spontaneous. And what that is who's doing the work. So you have 3 options. Either the machine does all the work, the patient does all the work, or there's a kind of an in-between where both does part of the work. So on the machine side, it's called a controlled breath. If you set the dial to 500, that is all you're getting. You get 500 every time. It's precision. 500 goes in, hopefully 500 comes out. But that's a different story. Assist, and the patient has no control as far as when that breath is delivered. They can't breathe in between breaths. They have to wait until the timing hits every 5 seconds for a breathing rate of 12 or whatever the machine is set up. For assist, the patient will inspire negatively, drop the pressure down. The machine recognizes that drop in pressure and it triggers a breath of whatever you set it at. If the patient's not breathing on their own, then the machine takes over and delivers a breath at that predetermined volume. And then finally, if you are if you're awake but you just can't breathe, like Christopher Reeve kind of situation where you have no diaphragm control, you can't make that inspiratory force to drive the ventilator to breathe for you. If you're awake and you can take a breath in, but you just need a little bit of help, the spontaneous or supported breath is just giving you that extra little oomph to give you the kind of the last half or so of the breath that you would have taken on your own. So as you get less sick, you can move from control to assisted to finally supported, and then eventually off, and then it's just blow by the trach or by the endotracheal tube and stuff like that. So here's kind of a diagram of how and who does the work. So you got your control breath where the patient does no work, but the vent does everything. Patient starts, vent takes over, and then finally able to do some or most of it, and the ventilator just kind of assists off. This would be similar to doing like CPAP or BiPAP. That's just an invasive version of CPAP/BiPAP. So now that you've figured out who's going to do the work, you have to figure out what are your goals for the ventilator. The ventilator needs to know when to stop delivering a breath, and it's going to do one of two things. It reaches a certain volume or it reaches a certain pressure inside the chest. And there are pluses and minuses to both. But for volume mode, on the knob or the dial, you say, okay, I want you to stop at 500 cc's of air, and then the lung says, okay, well, I am injured or I'm not injured, meaning the compliance will change. And you're still going to ram that 500 cc's in. And so if the lung is not injured, like you're going to surgery to have your gallbladder taken out, so you're going in with relatively healthy lungs. The anesthesiologist puts you on volume mode and says 500 with good lung compliance, which is a large, in this situation is a high number. They can actually quantify your compliance. So a large number would be a good number to have in this situation. And so you can see that as the volume stays the same and this number goes up, then the pressure is relatively small. So good or high compliance with a fixed volume equals low pressure into the chest, and that's what we want. We don't want to have high pressures in the chest because then bad things can happen. The chest can get overfilled with pressure and blood can't flow in, and all kinds of problems can happen. And so with non-injured lungs, pressure can stay low. As you get pneumonia, ARDS from burns, from bad infections, from we just had a kid at Children's, a 13-month-old, drink a bunch of kerosene and had flash pulmonary edema, and that's injured lungs from the inside. And so the compliance was really bad, and the kid had a stat of like 20% at one point. And so they were having trouble ventilating this kid because the lungs just wouldn't stretch open and they were collapsing down. Conversely, you can set the vent to pressure mode, and now your goal when you stop delivering a breath is met at whatever pressure you set it at. So generally we want pressures under 30 centimeters of water. And so what we do is we say, okay, go to a pressure of 22. And so the vent will go up and up and up and up until it hits pressure 22, and then it drops off. And so your volume delivered is a measure of how good or bad the compliance is times the pressure. And so the pressure is your fixed setting, and so volume is whatever is dependent on whatever. With good compliance, you get good volume. With bad compliance, you get bad volume. How's trapped outside? So injured lungs, once again, will have poor volumes if the compliance is bad, and you say you're he only gets one free pass, and then he's got to watch through the window. So, any questions on goals for I'd say 98% or 99% of emergency department patients are placed on volume mode because we are seeing a kind of trend and a slight benefit to setting patients on the volume mode as opposed to a pressure mode. You'll generally see a patient on assist mode, which is patient can draw in their own breath, and they'll say the goal is volume as opposed to pressure, and then we'll tweak it some more after that. So pressures, there are different areas of pressure in the chest, and these are some common ones you'll hear. You'll have your peak inspiratory pressure, or your PIP, your airway resistance, which is this pressure minus this one equals this. You have your inspiratory pause, which is how you generate this plateau pressure. You basically just take a breath in and hold it, and the lungs just kind of equilibrate and deliver on the vent, on the bigger vent. They can show you what the pressure is for that breath. So here's a graphic of where all the pressures are measured. So PEEP, hopefully everyone is at this point is aware of PEEP, and that's just kind of as you breathe out. See you guys. As you breathe out, you have a positive end expiratory pressure that's still remaining in the chest. And the way that you can deliver that on your own right now is you breathe out through do pursed lip breathing. That's the point of pursed lip breathing, is to create internal PEEP. As you take a breath in, or as the machine or you take a breath in, the air fills the lungs, and you hit this peak inspiratory pressure either by you or by the machine, and then this is all generated by the large airways, so your trachea and your right and left main bronchi, and maybe into the little bit of the bronchioles, the proximal bronchioles. But it really has nothing to do with the low down, the alveoli, or the tiny little bronchioles. It's more the big middle to upper airway. So asthma patients will have bronchiole and bronchi constriction, so they'll have high PIPs. But down past the bronchoconstriction, where the alveoli are, they're relatively uninjured, so they'll have normal plateau pressures, which is the pressure at the thin wall, grape-like structure alveoli. So you'll have two different numbers, and you'll have to kind of interpret, okay, this one's high, but this one's normal. What does that mean versus this is high and this is high? And the longer you have a patient on the ventilator, so like if you were doing a long distance transfer for whatever reason, let's say here to Columbia, and your patient was pneumonia, and they started to develop, they started to develop both increased PIPs and plateau pressures. You have to consider all of these conditions as, well, obviously, hopefully you would notice if there's a burn on the chest, but some of these internal issues, you have to decide, okay, is this something I can deal with, or I just need to get them to the hospital and get them to the physician that will stick a tube in them or give them some kind of medication. But you can see over here, increased PIPs with unchanged plateau pressures. These are all things you guys can fix. If patients kinking or biting the tube, there's secretions or plugging that you need to suction out, or you need to give bronchodilators to open the patient back up. And then over here, if you have both increased PIPs and plateau pressures, you have to consider tension pneumothorax because it's just squeezing the entire lung, both upper and lower. Question on pressures. So the pressure alarm will be on both ventilators will generally be for the peak pressure. So you can see that the patient will have increased peak pressures for both. On both columns will be increased on both, and the ventilators will say increase. But then you have to figure out, can I measure my my plateau pressure and rule out all of these things and say, oh, it's just one of those, or do I not know and I have to kind of just start giving various treatments and stuff like that? Check the tube, suction down the tube, just put an inline neb and stuff like that. So the vent will start to alarm at you, and you may have to change the alarm settings on the vent if you came into the patient knowing that it was like you had status asthmaticus, and this was just as you guys have seen up here, just the incredibly tight lung patient who you can't get any breath in. The vent's going to be screaming at you that there's increased PIPs from the start. So you may actually have to raise the peak pressure alarm just to get a breath in, because if the pressure is too high for the vent, it won't deliver a breath. So let's say you get a patient, you're giving them your treatments and whatnot, and they're not getting it better, you need to intubate them. And so when you're getting that breath, it's like super hard. Who here has ventilated by hand an asthmatic patient and struggled to get a breath in? Well, if we could put a pressure sensor on that, it would be, let's say, 50, 60, 70 centimeters of water. Well, the vent at baseline, which when we turn this on, it doesn't say on the outside. It'll say, let's say the pressure is 50. The pressure alarm is at 50. So if the pressure in the chest is anything above 50, the vent will deliver a breath, and it'll just keep alarming at you. And the patient will not get a single breath until you do one of two things: either fix the asthma, which is not going to happen right away, or you have to raise the vent alarm higher just to get a breath in. And so you have to do a little bit of troubleshooting. But let's say this is a trauma patient with a gunshot wound to the right side of the chest, and they're getting peak pressure alarms, and you have unequal breath sounds. What's something that you can do to try to relieve the pressure on that side of the chest?
Decompress.
Correct. And then you might get an immediate drop in pressure, and the vent starts delivering breaths. So there is a little bit of work that you have to do, troubleshooting with the pressure alarms and knowing the pathophysiology of what's going on with the patient. Now, hopefully you don't have like a gunshot wound and someone having status asthmaticus, because then it's just bad all around. But you can get an asthmatic patient who can pop a bleb and then turn into a tension pneumothorax. Generally, we don't see that too often because we don't intubate many asthmatics as much as we used to, but it is still possible.
So how'd the kid do? The drank Harrison?
It went up to the PICU, was probably going to get put on ECMO, which we will talk more about in the next hour.
I was just curious.
But I honestly don't know. I'm going back to children's tonight, and it wasn't my patient, so I don't even remember the name.
It's an interesting case.
Yeah, I have to talk to Pellerito to get the patient's name to find out what happened. But it did not look well. But hopefully, the PICU can turn the kid's lungs or turn the kid's lungs off.
Would they use dialysis on him?
Generally no. It's really just kind of lung support, lung rehab, letting the lungs heal. I don't think that there's any. It's not like it's not like it's in the bloodstream as much as it's just sitting in the lungs injuring them. I mean, some will get in, but and it's not. I don't think the kid drank much. I think it's more just inhaled it a little bit. But at 13 months, there's a large surface of lung to a little body, so the lungs were not happy. So that kid was definitely going to have increased hips and plateau pressures because he or she was already in ARDS. So now, do you see or do you recognize hearing these in the hospital all on transfers and stuff like that? Like, does this start to seem like a patient you may have transferred in the recent past? Most patients, like I said before, will be on volume mode assist control. And then, let's say you got just a patient who's trached but awake and just living at a facility. If they are awake and doing some of the work, they'll be on pressure support, which is just like a CPAP or a BiPAP or something like that. This one gets used every so often, volume mode. This is SIMV. It's kind of I don't want to call it boutique, but people were trying to be like fancier than they needed to be when they use this version. They can get a pretty good response with volume assist control, and it's a little bit less work than SIMV with pressure support. And this is kind of one of the newer kids on the block, pressure regulated volume control. So it's a mix of these two. So the volume is the goal, but they set some pressure limits in there. It just requires a fancier ventilator. I don't think our vent can do that. I think it requires a hospital vent or one of the newer ones like the Hamilton or the Ravel or these other transport vents that you'll see, like the critical care transport teams, both for ground or air using. So kind of a graphic representation. So if you have volume assist control, it's either assisted or controlled, depends on the little tweak in the monitor. The independent variable is volume, and then the dependent variable are these pressures. So you'll change this, and it's kind of these will depend. It kind of depends on these. And then here's some notes just to what to watch for. I'll give you this in a sheet version just so you can have for reference. Where the goal is to eventually have like a laminated placard with both ventilators, so you can reference and be like, oh wait a minute, this is alarming, the patient's on this setting, I should do this, this, and this. So now in what's called lung protective ventilation. So back in the pre-2000s, people would get set with tidal volumes of 10 to 15 milliliters per kilogram of weight for each breath. So if I weigh 70 kilos, they would give me 700 to 1,000 per breath. And they were seeing that over periods of days to weeks to months of ventilation, that people would get injured lungs, they would never come off the ventilator and whatnot. So it's, a group of ICUs got together and said, hey, what if we drop the ventilation, the volume per ventilation down, but back it up with some PEEP and some other metrics. And so they found that they actually saved lives in the ICU if they gave less volume and increased the use of PEEP. So you stent the lungs open with PEEP, but then you just deliver smaller breaths in between. And that started in the ICU, and then as hospitals became overcrowded and patients that were destined for the ICU never got up there, we started moving the ventilation strategy down to the emergency department and said, okay, as soon as you intubate the person, either before or after they have ARDS, start them on this ventilation strategy. Well, my coworkers at Barnes, a bunch of the EM ICU doctors there, they came up with a big trial that found that if we do this in the ED, we save lives. And it's actually really easy. It's very protocol driven. The respiratory therapists are on board with this, and they kind of work within these numbers. And it's all height based. Your lungs, if I add 300 pounds to all of you right now, your lungs don't change in size. So regardless of your actual weight, it's all based on your height. And so we measure by height, and then we calculate out with some formulas, and then you get a actual, what's called an ideal body weight. So where am I? I am 5'11". So my ideal body weight is 75 kilos. That works out to 165 pounds, which I'm definitely not right now. And at 7 cc's per kilogram, which is in the middle of the 6 to 8, my ideal breath is around 527. Well, if you remember from my BVM study that we did a couple years ago, a single finger pinch with this BVM is about 800 cc's per breath. But if we switch to the PEDS BVM, which we did, we were ending up in this range right here. So you can see that to match what the ventilator should be doing for the patient, we needed to get rid of this BVM. And that's why I basically tried to get you as close to this with something that tells you nothing about how much air you're delivering. So even let's see, this is 6'4" person should only be getting about 600, in the middle. And then for a female, they get a little bit less just because of the formula. So their volumes are even lower than the males. And you should be trying to do this both on scene and during interfacility transports. PEEP valves. So with the lung protective ventilation strategy, PEEP valves or PEEP in general was utilized more. And so, does anyone know what the fraction of inspired oxygen is in the room right now? What's the percentage of oxygen in the room right now? What? 21. So that would be 0.21 or right over here. So 100%, that's, if you were sucking right off the bottle, or on a ventilator that asks you what your FiO2 is, and I'll show you this more later, but even this vent has this, our I'll call our stupid vent. It has a knob right here for either, this is for 100% or down to 50%. And it gives you two options. And so oxygen is a drug. Any drug can be overdosed, and patients can actually be harmed by too much oxygen. So you can see that very little people very few people need 100% oxygen, and more people need under 50% than anything else. And so we want to match our vent settings to a goal right here, 88 to 95%. And you do that by titrating both the FiO2 and the PEEP. So this vent over here does allow an FiO2 to be changed. Right here, it's called the percent oxygen button. It can do vent management without oxygen at just delivering at 21%, which is just the equivalent of a BVM on room air. But you can actually then, it'll draw in and blend room air and 100% oxygen from a bottle or from the wall. So we basically just give a chart to the respiratory therapists or the nurses and say, okay, start out here, and then just keep stepping up in sequence. So if you have to go, let's say you start out here and your sats are 85%. Well, give them a little bit more PEEP, 86%, a little bit more PEEP, 87%, a little bit more PEEP, 80, and then as you go up, okay, finally, man, I've gotten like to 14 of PEEP, let's try to give them some more oxygen. And you limit the chance that you get what's called hyperoxia, which can damage the brain, the heart, the lungs. You can overdose on oxygen, which is a problem we can't usually reverse once it's occurred. Obstructive lung disease, so status asthmaticus, COPD exacerbation, and then anaphylaxis are the three conditions that you generally think of with obstructive lung disease. These people can usually get air in because but they can't get air out. So it's kind of a one-way valve. You'll stretch the lungs, the bronchioles and bronchi open, and the air will go in, and then it'll slam shut, and that bronchospasm will prevent the air from getting out. And that's why you see that prolonged expiratory phase, both when you're watching the patient, as well as on the end tidal, you get that shark fin because the air is squeaking out. So you see end tidal still rising, as opposed to quick out and then drops off. Well, you have to give them time to exhale on the ventilator before you deliver another breath. So what we generally do is we get some air in, and then we just leave it sit and let them breathe out, and then we give them another breath. So you actually will do what's called permissive hypercapnia, and that means that you are allowing them to have higher than normal end tidal CO2s or blood CO2 levels, so that you don't breath stack them. And over time right here, this is the same amount of breath. So let's say this is 500 per breath every time, but if they don't get all 500 out and you deliver another 500, well, now you've got all of this air in the chest, and then another 500, and another 500, and then eventually they go into, they will essentially go into like a tension pneumothorax type picture, or they'll just clamp off their IVC and SVC, and no blood will get in, and they'll go into cardiac arrest on you. So if you ever had a asthmatic patient code on you right after you started BVMing them, it's generally because they got positive pressure ventilation in a setting of already overfilled lungs, and you prevented any blood from getting back into their heart, and they became hypotensive on you. And then you probably got ROS back within the first round of CPR, because all that chest compression emptied all the air out of their chest, and the blood pressure immediately returned. Has anyone seen that happen? I mean, you guys have probably been doing this long enough to, it's probably happened at least once or twice on you. You may not have realized it.
Yeah, I was going to say, and not that I can.
And then if you've ever had a patient already on a ventilator who coded, in this situation, who coded on you, one of the first things you should do is disconnect the vent tubing from the patient and let them breathe out. And sometimes we'll actually get on their chest and push down and just forcibly exhale all the gas out of their chest, and then the blood pressure will return. It's like relieving a tension pneumothorax that's inside the lung as opposed to outside the lung. So be scared of an intubated asthmatic or COPD patient because the air gets in fine, but it can't get out, and then generally they go to cardiac arrest. If you have a vent, not these ones don't do it, but if you have a vent that gives you those loops and grafts and whatnot, you need to see this flow reach up to 0. So this is positive, this is negative, this is the 0 line. This flow, this is the flow of gas in either direction. So breath in, gas flows into the patient really fast, and then it drops off, and then it starts to flow out. Well, as it flows out, because it's taking a long time, if you don't give the patient a chance to exhale, and they need to get to here to be at a 0 flow, you've already given a breath, and this right here is called auto PEEP. Auto PEEP is internally generated PEEP because of too much pressure in the chest. That's bad. So this is our stupid ventilator as opposed to the smart ventilator over here. So up here is our relief pressure alarm. This is what I said that it generally is set in the 30 to 40 range for non-bronchospastic lungs, but you may need to put a pressure up to 60. If you are at a pressure of 60 and the patient is still not getting breath, you can't use this ventilator. So if you have a really bad asthmatic and this is the vent that you brought to the patient, you can't transport the patient with that ventilator. You either need to go to this ventilator over here, or you need to do it by BVM and hope to God that you don't overventilate them, because this one just doesn't allow for pressures that high. And then down here is your FiO2. You either have 100 or 50. Generally, most patients do not need 100, so use as little amount of oxygen as possible. You can see here this is control mechanical ventilation, so it just does control at whatever, this is the breath rate. So most patients need between like 15 to 20 breaths a minute at smaller volumes. So if you remember that chart, most people fall in this range, which this is old school thinking that goes all the way up to like 7, or their yellow go? Their yellow goes all the way up to like 1200 cc's. You do not need that much. Like at most, this should go to like here, and then after that, it doesn't allow anymore because this is all just danger zone. And most peds and infants are down in the 200, 150 range. Hopefully you're not ventilating them, or hopefully you're not transporting them, and children just come to pick them up because they have much better, much more sophisticated ventilators than these ones. This is our bigger, smarter vent. You have your on-off switch. These are kind of quick set modes, which we don't really utilize that much. And then you have a lot of different buttons. So here's your pressure alarm. Whatever it reads at, up to 99 centimeters of water. So a really bad asthmatic, you may need to